Hello and welcome to Learn from the Case. Today I want to awaken your curiosity with a new neurological case. I want to talk to you about a stroke. I prepared a presentation in 4 parts. This is part 4 of 4. I present some cases and make a first approach to the issue of a stroke. So let's get into the topic.
What is it? What's my full name?
Oh, come on.
What is it?
What? Mrs. Annie Prophet.
What's my maiden name?
Annie Goulahy.
Annie Goulahy? Where in God's name did I grow up? Dog Patch?
Oh, no, not there. Over in Goober, Idaho. That's a nuclear waste dump.
Where did I meet you?
Hank's Donut World? Seattle? You used to hang out there every night when you were still in the Navy. You remember?
I was in the armed forces.
I think I've still got some of those postcards you sent me from Okinawa.
The Navy?
Oh, come on, honey. You gotta know you were in the Navy.
No, I don't know. I don't know any of this, and I don't know you.
Have you seen how frequently characters in movies, series, or soap operas are affected by amnesia? I always wondered what injury could cause that. Then, studying and practicing neurology, I got some answers. There are many possible causes. Here, I am going to tell you about one of them. A lot of stroke patients have problems with their memory after a stroke, especially in the first weeks and months. It often affects short-term memory more than long-term memory. Someone might find it hard to remember something they have just been told, but might recall something that happened many years ago. Memory impairment, amnesia-type memory problems, is a key clinical manifestation of acute posterior cerebral artery stroke. Amnesia is more frequent and more severe after left stroke, suggesting a left hemisphere dominance of the two memory systems. Domain-specific memory appears not to be strictly lateralized, since deficits in verbal and figural memory were found after lesions in both sides. Extra hippocampal lesions might also cause memory impairment. Amnesia in subjects with left hemisphere lesions was more frequent and more severe, with significantly lower scores on the verbal memory test. Normal performance of figural amnesia were prevalent after right hemisphere lesions. However, no amnesia subtype was strictly tied to left or right side brain damage. Hippocampal and thalamic lesions were common, but 30% of lesions were extra-hippocampal located in the ventral occipitotemporal cortex and long-occipital white matter tract. Most amnestic patients lacked awareness for their memory impairment. In 1900, the Russian neurologist Bekhterev described a patient who experienced amnesia related to stroke, while the postmodern study revealed bilateral suffering involving the uncles and the among home. In 1961, a likewise postmodern study of a patient with bilateral infarctions in the posterior cerebral artery territories established a stroke as an etiology of acute and, in particular, persistent amnesia. Postmortem cases report transient amnesia in unilateral posterior cerebral artery stroke. Benson described 10 patients in whom amnesia was accompanied by hemianopsia in posterior cerebral artery territory strokes, 6 bilateral, 4 unilateral. In radionuclide brain scan. In 1993, Odd and Saber described 3 patients with unilateral posterior cerebral artery stroke with hippocampal involvement causing amnesia. The common feature in all unilateral cases was the involvement of the left hippocampus. Diffusion-weighted MRI is highly sensitive to even very small ischemic lesions, providing a strong contrast between affected and unaffected tissues, and offering more detail in stroke syndromes. In this study, we examined the morphological finding of DWI in hippocampal infarcts, an attempt to detect clinical and neuropsychological changes in acute hippocampal infarct patients. Here you can see a real explanation for acute global amnesia. This occurs very rarely in real life because, as we already said, the most commonly affected artery by far in strokes is the middle cerebral artery. Any other etiology of posterior cerebral artery syndrome, such as stroke, tumors, abscess, or others, could trigger global amnesia, transient or not. Now, to finish this presentation of stroke, I would like to mention some important differential diagnoses. Many dangerous central processes can be mistaken for stroke, such as subdural hematomas, intracranial hemorrhages, or masses, which also need to be recognized quickly. Masses, intracranial hemorrhages, and subdural hematomas can cause stroke-like symptoms based on location or mass effects on the same structures in the brain that are supplied by the middle cerebral artery, for instance. They would likely be diagnosed based on the CT and MRI that is performed in the acute setting when evaluating for stroke. Seizures, particularly status epilepticus, can mimic stroke due to gaze deviation and loss of movement, as well as global aphasia due to loss of consciousness. This is important to diagnose acutely, as well as it requires urgent treatment with benzodiazepines or anti-epileptic drugs. Remember always the non-convulsive status epilepticus. Demyelinating disorders such as multiple sclerosis might also be confused with stroke, giving presentation consistent with vision loss and numbness or weakness that typically will favor a particular extremity. This is something that will require an MRI with and without contrast to differentiate, as well as through history and clarification of symptoms onsets, as it usually is not as acute and likely waxes and wanes. Toxic, infectious, and metabolic differentials must be included as well, which is why several laboratory studies must be sent in the evaluation of acute stroke. Sepsis, uremia, hypo and hyperglycemia, hyponatremia, and hyperkalemia can all cause symptoms that resemble a stroke. Encephalopathic presentations due to these abnormalities and others can mimic stroke in that they can cause aphasia and apparent deficit in strength, which is why the assessment of laterality is so important in recognizing stroke versus some of its mimics. Complex migraines can mimic a stroke also. Some migraines might present with unilateral weakness or numbness. This is something that imaging cannot help diagnose. Typically, there will be a headache associated with symptoms, but remember, as a falcic migraine, the patient will likely have a history of migraines and similar symptoms in the past. This is something that requires a thorough history to diagnose. Usually, treating the headache will result in symptoms resolution. This can be dangerous and even fatal if misdiagnosed. Some psychiatric disorders might present with stroke-like symptoms, such as unilateral numbness or weakness. Examples of these are conversion disorder and panic attack. These are typically diagnoses of explosion and must be diagnosed based on a carefully obtained history. Vasovagal syncope can mimic a stroke as well. Two forms preferentially occur in adolescence: hair grooming syncope and stretch syncope, induced by stretching arms and neck upwards and backwards. Syncope induced by stretching is a recognized but rarely reported phenomenon in adolescents. To the author's knowledge, there have been only 13 cases described in the literature, and of these, the majority have been adolescent males. However, the precise pathophysiology is unclear, and both direct vertebral arterial compression and reflex mechanisms have been proposed. I leave this here. There are many more differential diagnoses. Search for more if you want, and leave them in the comments if you like to do that. And with this, I finish this presentation of cerebrovascular accident or stroke. Thank you very much for your attention. Keep researching and studying and be well. If you like this content, be sure to subscribe and follow me. See you soon.